integrated healthcare access pathways, particularly in focus with the Saskatchewan healthcare system. I'm Tayyib Shah. I'm going to share my experience on how I see the healthcare accessibility, especially when in the rural point of view, where the healthcare system is kind of fragmented and where we need a better understanding about the healthcare accessibility and the services, especially when the healthcare is needed, time-sensitive issues, and very like including emergencies, acute, occupational farm injuries, and those kind of things, and how you want to provide a complete accessibility to those services, and the methodological gap, isolated matrices, and where the conventional special studies access special accessibility to individual healthcare providers, mostly like individual healthcare professions, not in together to see the providing a complete solution for a particular case or injuries. There is opportunity. So the idea behind this whole presentation is to try to see where we can enhance our research methodology and having a better accessibility measures to understand the overall healthcare services at the provincial levels. So objective is integrated network-based geospatial framework that help to evaluate the continuous healthcare pathways across rural Saskatchewan. So there are three major areas which special access is going to be involved in the study: optimize service distribution, reduce disparities, and improve healthcare delivery for agriculture and rural populations. So before that, going to in the new idea, what's the background of that idea? So I want to just introduce what me and my colleagues and my peers and my supervisor we have done together, and that will help to frame what the new idea we are heading in that way. So first we have worked together over 10 years, continuously working on this area, multi-healthcare provider expertise. We have accessibility in different contexts: primary healthcare, family physician, nurse practitioner, physios, optometrists, and those are so many other professions. We did mostly the individual and isolated healthcare accessibility measures. And in terms of the geographic levels, so we did like a local level, urban, rural area as well, provincial, national, and international context well. So there are a few examples which I want to share in that context. We have published the papers where we went on the foundations for special access modeling, and where and then also apply in that methodology in other professions in the physiotherapy and compare them with other rural and urban areas. And also we determine the like try to be combine two family physician and nurse practitioner services together as a kind of idea, just to see overall primary health care coverage. And that was a comparison between the two provinces in Canada, Alberta and Saskatchewan, at the municipality levels. And then we compared those accessibility scores with the high population healthcare needs groups, and that is bivariate analysis. You can see the accessibility, see the mismatch with the population healthcare needs that can highlight. So this is a kind of study which established one and another healthcare profession is optometry services, and that is a kind of things which we try to do at the national level, and using the same approach with other important parameters or variables. For example, utilization of services from Canadian Community Healthcare Services, and then other socioeconomic variables based on the census data set. Recently, we did some comparison with the family physician over the time. It's not just a one-time, it's a repeated cross-sectional studies, and where we see the snapshot of the health family physicians working across the Saskatchewan, and then see over the time, is there any change or significant change where the patterns are changing. So those are the experiences I'm not talking about these studies particularly. I'm just trying to explain you what kind of research I was involved in. So having this kind of experience and working with a few international studies as well. For example, in New Zealand, physiotherapy access services was analyzed at the national level, and we have a couple of publications based on that. So most of the things which we doing in healthcare accessibility, where the GIS is involved, of the using a floating catchment areas method, which is kind of popular. And when I was a student, we with my supervisor, we developed this methodology, and then I continue with that methodology to apply it in different contexts, which you have seen few of the examples. So what exactly this floating catchment area methodology is doing? We have two streams: healthcare providers, which is on the left side, and the right side we have a population data. When we put them together, and there's the methodology we call the three-step floating catchment area, and then as a result we get a score, and that score we do the regress or bivariant or multivariate analysis with socioeconomic variables at different geographic and different sources, depending on. So this is the basic core course, but exactly when we talked about in terms of the floating catchment areas. So for example, these are the location of the physios with the number of physios, the population sites, and then we have a proximity by defining buffers. There are different ways to define those catchment areas, by drive time or radial buffers, and then we have the relationship between those, and then apply the decay function to calculate the overall population within the catchment area. Then defining the catchment area needs a global cutoff value. Up to that, the influence of that healthcare services could be analyzed, and then calculating the healthcare provider to population ratio, and then the same process be repeated in all. And then in the second step, it's the reverse, other way around, using the same approach. And then the third step is using the unit of analysis to aggregate these scores, and so those scores are basically the third step where we can calculate it. So this is a kind of core idea behind it, and which I already shared. The New Zealand level, we apply that approach over there, and then we have some bivariant analysis by using a different population, the subpopulation groups, and to see the bivariant or those analysis. You can see the socioeconomic using the deprivation index, these kind of things. So having this background and work with a different like geographically, if you talk about like provincial, national, and somehow to some extent at an international level as well. So no, what we are trying to do is all together when we see this scenario, so we have integrated pathways where patient's journey is basically defined the healthcare accessibility is a sequential multi-stage timelines rather than a single isolated visit to a provider. So that's the concept. We have interdependent chain is also important, how the complete healthcare for a particular scenario requires a sequence of distinct services operating together, such as emergency transport, acute clinical intervention, physician diagnosis, stabilization in terms of the pharmacies, and functional rehabilitation with the occupational physiotherapy therapists involved in that case. So that's all the group of services that's all together. We need to see how the overall access is in that case. So system aligned navigation to shift the research and planning focus to match how patients utilize the healthcare grid in practice. So weakest link principle from a geospatial modeling perspective is highlights that geographic accessibility is only as strong as the most restrictive bottleneck in that care chain. If any single link is physically or temporarily out of reach, the entire pathway is fragments, delaying patient recovery and return to work timelines. So we proposed three major areas: the multi-source input layer, where we want to be kind of the interface of this dashboard interactive tool, which will provide you the one access to the different healthcare providers. So it's the end user choice how they want to be choose making the combination of those healthcare services, and then doing the health, different kind of methodology, but mostly focused around the floating catchment area, and that will be the choice versus the simple container approach where you want to calculate the physician to population ratio at the unit of analysis and those kind of things. And then we can have a specific options in the parameters which end user will have, like between the travel distance, how to define the catchment area, actual travel time, radial distance, or any other combination of those distance decay to combine with those kind of things. So there will be a number of options which end user can choose and make the decision to how they want to calculate the accessibility and including the global catchment area, because different healthcare services have a different reach and they have their own buffer zone. So we need to be apply it according to the local experiences. The policy aligned action dashboard further will provide you the outcome, how you want to select. There will be a different display, dynamically aggregate the results at different unit of analysis, which is normally the policymakers want to be seen in the health units or municipality levels and other. If you want to talk about the urban areas, it will be more neighborhood levels. And then there will be a scenario. So the end user want to see the scenarios where they have poor accessibility, want to see how the accessibility can be changed by including or removing some healthcare services and build some scenarios. And full-time equivalent is another case where you cannot apply it. And then if scenarios are also there, if the retirement cases that lost, like people are different age groups and they want to see how the scenario after that will be there. So there will be a lot of options will be there. So the proposed portal and overview is basically where we will be providing all number of healthcare providers there, but the logic between them is basically either you have a direct link with the those registries, and or we can one time we can download and update the data, or we can also provide the option to upload your own data if you have the list, and then you can continue with this analysis. In terms of the population data, we usually prefer the census, and census in Canada is every 5 years, so it means we can add those last few census and up to the dissemination and or at the dissemination block level. So similar cases could be done in other countries as well. So this is the overall idea which I'm working these days, and I would like to see if you have any comments and feedback on that. So these are the further details which I have already explained, like the how the different process will be go. And one of the idea is that you're coding a full-time equivalent stats. We need to be work a little bit on that, and then also we can try to be de-identified the data sets in case which is required. And then their multi-location challenge is a challenge in healthcare system, but there are a way we can apply some proxies to determine those kind of things in that practice, especially to capture the healthcare providers working more than one location. And interface, which I also explained, like multi-user selection, temporal tracking sandbox, and then demand baseline calibration and accessibility variables. We have a different kind of parameters they can use. And the results interface will be the aggregation, policy relevance, and diagnostic tips will be where you can have a number of choices where the results can be aggregated and exported. So that's kind of things which I have this idea, and I have a number of areas which we can like achieved moving from static to the are we going more dynamic mapping, time series is also a possibility. So if, as the information is maintained, or you have a different version of the healthcare practice location, so you can use and through the time series analysis as well. Trend analysis identification is on the one of the plus point in that case, and we can build the scenarios, and those are already explained. And proactive risk detection is also part of this, when especially the fragile zones are dealing with that. And evidence-based evidence-informed planning is the main primary focus of this whole new activity. Anyway, so active policy intervention sandbox, which is an optimization canvas and allows clinical planners to virtually add or relocate healthcare assets, or placing a new physiotherapist or occupational therapist planning directly on the interactive map, and then they can recalculate and see the difference between them. And there are other recompute options are there based on the network analysis or simple and before and after scenarios. There's a lot of kind of interventions and situations and scenarios that are available, will be available when you will be dealing with this portal. Thank you very much. And if you have any questions, let me know. And I would like to be continue on this work. And if somebody will have some suggestions, I will welcome and try to be incorporate those one. Thank you very much for watching this video.